Hi, my name is Michael Weiler. I'm a pharmacy student at DuVille University, and I chose this topic because of my interest in oncology and my hope to work with oncology patients in the future. The title of the paper was Radiotherapy combined with Nivolumab or Temolizumab for newly diagnosed glioblastoma with unmethylated MGMT promoter, an international randomized phase 3 trial. It was published in Neuro-Oncology in 2023. The primary objective of the paper would be to determine the efficacy of nivolumab in conjunction with radiotherapy in comparison to temolizumab in conjunction with radiotherapy in glioblastoma with an unmethylated MGMT promoter. The primary efficiency measure would be to evaluate the efficiency of nivolumab plus RT in increasing the overall survival of patients at the 24-month period using the Kaplan-Meier plot. The study design, it was a multi-center, randomized, open-label, phase 3, active comparator superiority study, where patients were stratified by degree of tumor resection, complete versus partial, at baseline and randomized at a 1-to-1 to receive NIVO plus RT or TMZ plus RT treatment. The subjects, adults were aged 18 to 83, were enrolled at 124 sites across 19 countries with newly diagnosed supratentorial glioblastoma with an unmethylated MGMT promoter. The inclusion criteria for the study, adults had to be greater or equal to 18 years or older, newly diagnosed, histologically confirmed supratentorial glioblastoma with an unmethylated MGMT promoter determined by methylation-specific polymerase chain reaction assay. They could not have prior treatment for glioblastoma beyond surgery, and they had to be a part of the Karnofsky Performance Scale greater to or equal to 70, which allows patients to be classified to their functional impairment. This was used to compare effectiveness of the different therapies and to assess prognosis in individual patients. Less than 70 indicates cares for self, unable to carry on normal activity or to do active work. Important exclusion criteria, recurrent or secondary glioblastoma. They've undergone a biopsy only for glioblastoma at surgery. They had tumors in the past harboring IDH1 or IDH2 mutations. They have unresolved central nervous system hemorrhages. They have had metastatic extracranial or leptomeningeal disease, or active or known suspected autoimmune disease. The study period was after randomization. Each patient was dosed every 2 weeks for 8 cycles, and then the dose was doubled and administered every 4 weeks until disease progression was confirmed. A follow-up was then conducted after a 24-month period. For monitoring, disease status was assessed during using contrast-enhanced MRI at baseline, beginning at 4 weeks after radiotherapy completion. Then disease status was evaluated every 8 weeks until progression per response assessment in the neuro-oncology criteria, RANO. Data analysis. Primary analysis of the primary outcome measure was done per protocol design with an alpha set at 0.05. Power was calculated for the primary outcome measure with a minimum effect size of 390 participants to have at least 90% power. The study met power with 560 individuals, 280 in the treatment group and 280 in the comparator group. For the data analyzed, it was overall survival, OS for short. Overall survival for the study was the length of time from either date of diagnosis or the start of treatment for glioblastoma. It measured the overall survival to see how well each treatment arm worked in this phase 3 trial. The type of data was interval ratio. The statistical test that was used was stratified Cox proportional hazards model, and it was selected to be appropriate for this article. For results, the results showed that TMZ plus RT showed statistically significant data at a P at 0.0037 for the primary outcome tested over the course of 24 months and not the NIVO-RT treatment, the intervention group. The median overall survival was 13.4 months with a 95% confidence interval from 12.6 to 14.3 months in the NIVO-RT arm and 14.9 months at 95% confident interval from 13.3 to 16.1 in the TMZ plus RT arm. So for tolerability, this chart listed down below, I'll talk about in a minute, is from the experiment depicting the adverse effects that were present in the study. Any grade treatment-related adverse effects were reported in 72.7% of patients treated with the NIVO plus RT and 75.6% of patients treated with TMZ plus RT. The most frequent TRAE was fatigue at any grade of disease at 19.1% in the NIVO plus RT arm, and nausea with any grade of disease with 29.1% in the TMZ plus RT arm. 3 treatment-related deaths were also reported in the NIVO plus RT arm, with vasogenic cerebral edema, sudden death, or respiratory failure, with 1 respective death falling in each category. After receiving 10, 7, and 10 infusions of NIVO respectively, no deaths were attributed to treatment reported in the TMZ plus RT arm of the study. The author's conclusions were based on the results presented in the study. The use of immunotherapy with NIVO is not recommended to replace chemotherapy with temozolomide. The strengths of the article whose power was set and met. The statistical tests was appropriate. It had appropriate inclusion and exclusion criteria. The evaluation measurements were appropriate. It was randomized at a 1-to-1 ratio. Duration was correct. The dosing was met on LexiComp, and a proper conclusion. For the limitations of the study, there was a blinding issue. In this open label trial, both investigators and trial participants were fully aware of treatment group of the participants and are in what treatments are assigned to them. In this open label trial, to compare different treatments or to gather further information of the long-term effects of new drugs and their treatments. A better understanding of glioblastoma immune evasion mechanisms to improve immunotherapies was also a limitation. Glioblastomas maintain an immunosuppressive microenvironment by using many variables, including program death ligand 1 expression. These include tumor and brain-specific mechanisms that include low tumor mutational burden, recruitment of other immune checkpoints, decreased T-cell responsiveness, inhibitory cytokine production, interactions between the central nervous system microenvironment and microglia, the predominance of myeloid cells, and the plasticity of lymphocytes in TME, and frequent corticosteroid use. A key limitation that the authors noted in the study was the lack of immune predictability biomarkers and comprehensive genomic characterizations due to the limited availability of tumor samples. Therefore, novel biomarkers do remain to need to be formally explored. In addition, this study did not consider potential effects of the timing of program death ligand 1 blockade relevant to radiotherapy administration, which subsequently has been demonstrated to be a possible consequence of some preclinical non-glioblastoma multiforme settings. With the level of evidence being 1 and major, my recommendation, I would not recommend NIVO plus RT as therapy over TMZ plus RT in the treatment of glioblastoma with an unmethylated MGMT promoter based on the final justifications. For efficacy, it was a well-designed level 1 trial with only blinding being a limitation. It demonstrated that NIVO plus RT was not superior to TMZ plus RT on improving the overall survival of glioblastoma with an unmethylated MGMT promoter. In terms of overall survival, there was a statistically significant difference between the two groups over the course of 2 years in favor of the comparator rather than the intervention at a p set at 0.0037, being significant. For safety, insignificant differences were found in the TRAEs, the adverse effects, reported with 72.7% with the nivolumab plus RT treatment and 75.6% with the temomulazide and RT treatment. There were 3 treatment-related deaths in the intervention group with no treatment-related deaths in the comparator group. The cost of nivolumab with 10 mg per ml per lexi is around $12,072 for a supply of 4 mLs. Extra costs may occur if the NIVO RT in terms of quality of life, respective treatment, emergent adverse effects, which could bump the cost. Special considerations and populations. Based on the exclusion criteria, there were several populations that were taken out of consideration for the efficacy of the drug, and this study was done only for newly diagnosed individuals, so it would never cover those who had poor prognosis, progression in other respects. Thank you for listening, and let me know if you have any questions.